Assalamu alaikum, everyone. Can you hear me?
Gee, I can
Yes,
hear
sir,
you,
we can
Dr.
hear you.
Sohaib.
Okay. My name is Dr. Sohaib. I'm working as a consultant anesthetist at Khan Hospital and also doing a surgical ICU. So today, our presentation will be by Dr. Saad Rehman. He's a very good friend of mine as well. He used to come to take you regularly on our conferences as well. So he will be talking today on nutrition. He's working as a consultant anesthetist and intensivist at Shaukat Khan Hospital. Uh, so, Dr. Sat, can you share your screen as well so we can just start the presentation right at around like 8 a.m. 8 p.m. So, I will request everybody to mute, keep their mics mute. Uh, please write down the questions. You can just share in the message box as well. So we will, at the end of the presentation, we will take the questions and hopefully we will have a good next 1 hour by like learning the nutrition and the critical care. So over to Dr. Saad.
Thank you, Dr. Sohaib. Can everyone hear me?
Yes, Dr. Saad, you are loud and clear.
Okay, and can you see my slides?
Yes, we can see your slide. You can just switch it to the like presentation. Yeah, we can see.
Okay.
You can just pop to the next slide so we can see that these are slides are changing or not. So we can just check it. Yes.
Okay, so I just
it's changing. Yeah, it's changing as well.
Okay. So thank you, Dr. Sohaib, for the kind introduction. It's always a pleasure to be involved with PSA Karachi and in these lecture series. So this is my second talk in these lecture series. So I'm going to be talking about a very important topic in critical care, which is about nutrition in critical care. So it's sort of a dry subject, um, and there's not much um, to start with. The work done in nutrition it's still relatively new subject. So about 20 so nutrition as an as a factor in outcomes in critical care became recognized in the last 20-25 years. But over the last 10 years, there's been a lot of work done. And what I'm going to try to share with you is the new evidence that has come up in the last 10 years and what clinicians in critical care are doing with regards to nutrition. So I'm not going to go into a lot of detail. It's a very big topic which can there are chapters and chapters written in most of the critical care books regarding critical care. But what I hope is that at the end of this talk, the participants will have a working knowledge of how to approach the nutritional needs of a patient admitted to intensive care. So I don't have any conflict of interest to declare. So this is a common scenario that we see in our ICUs. So a 64-year-old male with history of diabetes, mellitus, hypertension is admitted to ICU with pneumonia and ARDS. He is intubated, sedated, and on vasopressor infusions. He has a history of ulcerative colitis with repeated exacerbation. And on examination, he looks emaciated and has a BMI of 18. So what we're going to cover in this talk is what is this patient's nutritional risk, what are his nutritional needs, what and how will you deliver nutrition to this patient. So we're going to be talking about the normal body nutritional needs. We're going to be talking about what happens to your nutritional needs in stress. We're going to be talking about assessment, a bit about bundles, and we'll end with some unresolved questions that there's a lot of work going on. So I'm not going to talk about the different types of commercial feeds that are being used in intensive care. And I'm also not going to go into details of formulations and preparation of total parenteral nutrition. So over the last 25 years, we still have a lot of questions, but there are some questions that we've resolved in terms of nutritional needs. So the first question is to feed or not to feed. So most of people who started doing ICU in the last 20-25 years, the general consensus was that you should that feeding is something that should be put on the back burner. So you don't. So once the patient is really unwell, you didn't have to worry about. But thankfully, this has been the last 20 to 30 years. And we know that if you don't give feed to patient or you don't meet their nutritional demands, the outcomes of your patients are to be worse. Your patients are at increased risk of infections. They are at increased risk of critical care neuropathy, and they are also their time in ICU and the probability that will go get discharged is fully the consensus that patients who are related to ICU, they should be started on feeding any type of feeding, whether it is enteral nutrition or it is parenteral nutrition, it should be started early. So enteral nutrition, if the patient can take it.
Dr. Saad, your voice is distorting a lot. I think so that do you have a mic? If you can use a mic or the connection, I think so the connection is a problem.
I'll just change my connection and switch to another connection and see if that helps.
Yeah.
Okay, let's try again. Can everyone hear me?
Yes, now we can hear a little bit. Like now the voice is a little bit clear now.
Okay. So we know that whenever a patient is admitted to intensive care, if they've got a normal working enteral system, you tend to start feed early, within 48 hours of their admission to intensive care. For parenteral nutrition, if the patient can't take enterally, it is justified uh, it is justified to give some time to the patient before resolution of the symptoms. So you can wait 4 to 5 days, depending upon the condition of the patient, and you can start feed. And what to feed will cover in what nutritional needs does your patient have. So just to give you an idea of what the unresolved questions are, so we still haven't got any idea of how should we calculate the weight of a patient. So there are usually 3 types of weights that we use. So one is the actual body weight, and that is the weight of the patient when the patient is admitted to hospital. Ideal body weight, it's based on height, like we do in calculation of the tidal volume for our ARDS patients, and this is for obese patients. And the adjusted body weight, which is actually a combination of actual and ideal body weight. So it's actual weight minus your ideal weight times 0.33 plus ideal body weight. But I don't want you to remember this formula. Just have an idea of what the different types of weights are. And generally, the more obese the patient is, the more you want to go closer to the ideal body weight rather than going for the actual body weight. So if a patient has got a BMI of 30, 35, you want to actually stay closer to the ideal body weight that the patient has. So in terms of what are the nutritional needs of a healthy male, so a healthy male that has a weight of 70 kilogram, they need energy in the form of 2500 kilocalories per day, fat which should not be more than 97 gram, saturated fat should not be more than 31 gram, carbohydrates at least close to 333 gram, free sugars not more than 33 gram, protein 55 gram, fiber 30 gram, and salt no more than 6 gram. So you don't need to memorize these values, but what these values mean is that whatever the nutrition you're giving to the patient, it should make the largest percentage of that should be in the form of energy, and things that are not good for the body, including saturated fat and free sugars, they should be in low ratio as compared to other substances. So what are the normal body requirements needs? They can be estimated by using formulas such as the Harris-Benedict equation. So again, no need to memorize these on what they rely on. So this relies on the weight of the patient, the height of the patient, and the age of the patient. And by rough estimates, this comes close to about 25 kilocal per kg per day. So this is very important slide. So there is no one size fit all. So you can't just go by the sex and the weight of the patient, and that can give you an idea of the nutritional needs of the body. Uh, in essence, many of the ICUs have moved away from this one size fits all formula, and now they're doing what we call nutritional risk assessment, which I'll go in detail um, in my presentation. But essentially, every patient who's admitted to ICU has got different needs, and you can't use the same formula for calculating the nutritional requirements for each patient. So what we know about what happens to the nutritional needs in critical illness. So initially, whenever there is a stressful insult to the body, the initial phase is what was previously known as the ebb phase, uh, which was characterized by a sharp decrease in metabolism. This was followed by an early flow phase in which there is an increased catabolism and loss of muscle mass, and then a late flow phase in which there is muscle and tissue regeneration. So a short ebb phase characterized by hypometabolism occurs immediately after the injury, characterized by decrease in metabolic rate, oxygen consumption, body temperature, and enzymatic activity. The ebb phase is followed by a longer hypermetabolic flow rate marked by an increased catabolism with high oxygen consumption and an elevated resting energy expenditure rate. So now the new terminologies for these are the acute phase and the post-acute phase. So the acute phase consists of two periods: the early period, which is defined by metabolic instability and a severe increase in catabolism, and a late period, which is defined by significant muscle wasting and stabilization of metabolic disturbances and rehabilitation or persistent inflammation and prolonged hospitalization. So the resting energy expenditure is different in different clinical situations, and these pertain to the stress that the body is feeling. So if a patient is febrile, the resting energy requirements, they increase by 10% for each 1 degree rise above 37, up to a maximum of 40 degrees Celsius. In sepsis, the resting energy expenditure increases by 9%, regardless of temperature. And in burns, it increases by 100% if any size over 30% of burns. So when it comes to the constituents of the nutrition, so if we talk about protein, the protein requirement is about 1.5 gram per kg per day. And in severely catabolic states, this can go up to 2 gram per day. For example, in severe sepsis, burns, trauma. And the protein, they provide about 5.3 kilocal per gram in terms of the daily requirement of calories. Lipids provides 9.3 kilocal per gram. However, the calories from lipids should be limited to 40% of the total calories. And carbohydrates, they provide 3.75 kilocal per gram. So the remaining energy requirements after lipids and protein should be completed by adding carbohydrates. So caloric nitrogen ratio, what this means, it's the proportion of feed made up by protein is expressed as a calorie nitrogen ratio. So 6.25 gram of protein contains 1 gram of nitrogen. And the recommended calorie nitrogen ratio is 100:1. So I'll briefly go into the historical question again, to feed or not to feed. So we know that if we got a patient who's underfed, there is an increased risk of infections, there is muscle wasting, there is an increased risk of morbidity, and an increased risk of mortality. However, if we overfeed patient, that has got detrimental effects as well. And these include hypertonicity, dehydration, metabolic acidosis, azotemia, hyperglycemia, hypertriglyceridemia, increased time on ventilator, and other metabolic effects as well. So this is the crux of my talk, and this is, I think this is what I would want most of our audience to focus on, is assessment of nutritional status.
Excuse me, sir. Sorry to interrupt you, but there is a bit of distortion in the voice currently. Thank you, sir.
I'll try again. I think I've got an unstable connection, so I'll try again. So is it better or?
Sir, I think so that बीच में ये होता है कि आवाज बहुत बेहतर हो जाती है, फिर बीच में डिस्टॉर्शन होती है. तो अब आपकी आवाज बहुत बिल्कुल क्लियर आ रही है.
I think थोड़ा सा कोई इंटरनेट कनेक्शन का थोड़ा सा इशू है, क्योंकि उसी वजह से इसे ये हो रहा है. सो एनीवे, if अगर कोई डिस्टॉर्शन आती है तो मुझे बता दें, जल्दी स्टार्ट होगा.
आपकी आवाज अब बिल्कुल बीच में से वो बिल्कुल वो हो गई थी. It was all skipped out. अब now we can hear you again.
मैं एक सेकंड, मैं फिर से आई थिंक मैं अपनी लोकेशन चेंज कर लेता हूँ. जी, आवाज आ रही है मेरी?
जी डॉक्टर सादाबाद.
होपफुली अब प्रॉब्लम नहीं होगा क्योंकि मैं बिल्कुल राउटर के साथ जाके बैठ गया. Okay, so it's very important that every patient that is admitted to intensive care has an assessment of their nutritional status. So what we know is that patients admitted to critical care, they lose 10 to 25% of their total protein content and 10% of their body, depending on, and this depends upon their length of stay in ICU. So patients who remain longer in ICU, they have more weight loss as compared to those who get discharged early. So we know that malnutrition occurs in 40 to 50% of patients admitted to ICU. And we know that early and timely nutrition decreases 30 days, 60 days, and 6 months after discharge mortality. And it also decreases readmission rate to ICU. So since 2016, the ASPEN, the North American Society for Nutrition, and the ASPEN, the European Society for Nutrition, they have been advocating that all patients who are admitted to ICU undergo a nutritional assessment. So what are these nutritional assessments? So they started off with these four tools. So and then now we move to the scoring systems. So anthropometric measurements, which include skin fold thickness, mid-arm circumference, they're commonly used to assess different types of populations. But if you're specifically dealing with one population, these measurements, they might be similar, but if we got different types of populations in your ICU, these measurements, they differ between individuals. Biomarkers, they have been used. However, the caveat with biomarkers is that they're not reliable in acute illness. So albumin, pre-albumin, hemoglobin, transferrin, C-reactive protein, they've all been used. However, their measurements are not reliable in acute illness. BMI is an independent predictor of mortality in critical ill patients. However, it does not reflect acute changes. Nutritional tools is the way to go with the targeted history and examination of each patient and the use of tools and scoring systems. So we'll come to this. So we've got a broad range of ways to assess nutrition. So on one end of the spectrum, we've got tests like indirect calorimetry, which measure the amount of oxygen that the patient is consuming, and the amount of CO2 that is produced, and a ratio of that give rise to an indirect calorimetry. And on the other hand, the other extreme, what you can see on right is a very simple formula that can be used for every patient, which is we just calculate the weight of the patient and gives 25 to 30 kilocalories per kg per day. However, we still don't know which one of these formulas is a better way to calculate nutrition. So examination, extremely important. So loss of subcutaneous fat, look especially at the chest and triceps of the patient. Muscle wasting, looking at temporal region, deltoids and gluteals. Presence of edema and ascites are confounding factors that can affect nutritional assessment of patients. So coming to nutritional tools, so we got a number of tools that can be used for assessing nutritional status, and what they concentrate on is the age of patient, the physical status of the patient, presence of comorbidities, their severity of illness scores, including the Apache scores, the SOFA scores, and lab values, for example, the interleukin-6 values. So the first nutrition score that was given was the Modified Nutrition Risk Score in Intensive Care, MNUTRIC. This was started in 2014, and this has proved a valuable tool in assessment of patients. And you can see from the slide, the variables that it uses includes age, comorbidities, days from hospital to ICU, the Apache and the SOFR scores, and an interleukin score. And what do these scores mean? This means that if your patient has got a low Nutrix score, they've got a high incidence of nutritional morbidity and a high incidence of mortality. So these are the patients whose nutritional demands are high and who you need to concentrate on to give good nutritional support to these patients. And in terms of, sorry, it's the other way around. If you've got a high nutric patients, these are the factors that you need to take into account. Another score that is commonly used is the subjective global assessment score, and what that looks at the chronicity of problem as well. So factors such as the weight change, both chronic over the last 6 months and acute over 2 weeks. So the dietary habits of the patient before coming to intensive care, changes in food intake, the gastrointestinal symptoms that the patient has, including nausea, vomiting, diarrhea, and anorexia, and the functional impairment of the patient. Then we've got the GLIM criteria, the Global Leader Initiative Malnutrition Score that was introduced in 2016. And it looks at two types of criteria, the etiologic criteria and the phenotypic criteria. So the etiologic criteria include reduced food intake and inflammation, which is more of a subjective assessment, and the phenotypic criteria, which include weight loss, low BMI, and the reduced muscle mass. So another score that is used is the nutritional risk score, which gives the extent of the impairment of nutritional status and the severity of disease. So patients are classified according to two factors: the nutritional status and the severity of disease, and it ranges from a score of 0 absent to severe 3 in both these factors. And again, the higher the score, the more nutritional needs and the more at risk your patient is with regards to nutritional scoring. So what are the different strategies that you can use with regards to the diet that you give? So you can start off with an isocaloric diet. It's an energy administration of the patient around the defined target. Or it's a hypocaloric diet, which is an energy administration below the 70% of the defined target of the patient. Trophic feeding, which became very popular in around 2010, but has never gained momentum after that because of an absence of improved benefit, was a minimal administration of nutrients having beneficial effects, such as preserving intestinal epithelium, stimulating the mucosa of intestine to secrete hormones, enhancing immune function, and preventing bacterial translocation. Overfeeding is energy administration of above 110% above the defined target. And low protein diet is protein administration below 1.5 gram per kg per day. So what do the guidelines say? So I went through the guidelines for this talk through the Society of Critical Care Medicine, the Aspen American Society of Parenteral and Enteral Nutrition, and the European Society of Parenteral Nutrition. And what they advocate now is the use of nutritional bundles. So what is the constituent of nutritional bundle? It's first of all, it's to assess the nutritional risk of every patient that is admitted to ICU. Second is to calculate the energy and protein requirements. The third is to start early enteral nutrition within 24 to 48 hours. Fourth is to enhance feeding tolerance and aspiration prophylaxis. So you want your feed to be to get to the patient and to be absorbed and provide the needs of the patient. And fifth and last is for use of parenteral nutrition whenever it is indicated. So enteral versus parenteral nutrition, we'll just briefly go into it. So in terms of mortality benefit, interestingly, there has been no added benefit if you're using the enteral route or the parenteral route. So there have been number of studies which have looked at this, and they haven't shown any benefit in what type of feeding to use. However, there are benefits and of using the enteral route. So it's simple, it's safe, it's natural, and the risk of intolerance is low. Whereas when you talk about parenteral nutrition, it's expensive, it's labor intensive. It increases the risk of clepsy and infective complications. It can lead to fluid overload and electrolyte abnormalities. So when looking at patients, so there are specific focus groups that, in addition to the nutritional bundles that I've talked about, that you need to focus on. So it's the patients who are already malnourished before coming to ICU. So patients who have some chronic GI problem, for example, the patient in our problem with ulcerative colitis. So obese patients, it's very easy to overestimate their nutritional needs. The non-intubated patients. So why are these patients important? So these are patients who we're keeping on conservative management. So one example that comes to my mind is patients who've got respiratory failure, who are on non-invasive ventilation. So it's very easy to sort of ignore their nutritional needs, because these patients are at high risk of aspiration. They're not really eating well. They need to have breaks during the non-invasive ventilation for nutrition. And patients who've just been discharged from ICU. So remember those patients who've just been discharged, they're on the anabolic phase in terms of their critical illness, and those are patients who've got very high nutritional needs. So I'm going to end my presentation, and there's still a lot of unresolved questions with regards to nutrition. But hopefully, we'll find answers to think as our understanding of nutrition improves. So there have been attempts for early high caloric feeding in patients. So these are patients that you start them on high caloric feeding soon after their admission to intensive care. So studies have failed to see a benefit of early feeding in early high caloric feeding in patients as compared to normal feeding. Trophic feed, again, with the concept of preventing bacterial translocation and preventing mucosal injury of the gut, hasn't shown any benefit as yet, but there's still lots of projects going on and looking at that. So diet supplements, when I was appearing in my exams, they were very popular. So we used to have questions like use of zinc, ascorbic acid, vitamin C, omega oils. So they haven't showed long-lasting benefits. So the verdict on them is still out. Many people are using them. Many people are still not using. And post pyloric feeding. So this has been used a lot, especially in surgical patients and in patients who develop feeding intolerance. So these are patients with high NG aspirates, or patients who are not absorbing their feeds. And post pyloric feeding has been used as them, but it still hasn't gained popularity in terms of the initial feeding route. So initial feeding route is through the enteral route, which is by feeding tube in the stomach. So this ends my presentation. I'm sorry for the connectivity issues. So I've tried to keep my presentation to the new evidence and unresolved issues. So my apologies if anyone was expecting that I was going to go into basics of feeding. But I'll take any questions that you might have at the moment.
Thank you, Dr. Saad, for the very the evidence-based guideline for the nutrition right now. So, any questions anyone want to ask?
Assalamu alaikum, Dr. Saad. Really very good lecture. Tell me, mostly it is said that in COPD patient, carbohydrate should be restricted. Does it really matters? I want your comment.
Sorry, what was the question again?
Dr. Saad, he want to ask that the people who are having a COPD, and it is usually recommended that we should limit the carbohydrate intake in that patients. So, your comment on that, and it really makes difference.
So in terms of evidence, so there's no evidence that if you hold carbohydrates in patients with COPD, it's going to add any benefit. So COPD patient again is one population of patients that haven't got the best nutritional status when they come to intensive care. So these are patients that might have repeated exacerbations. They're generally not in a nutritionally well state. So what we know from the evidence, so there was a lot of work done in the early 2010s that thought that if you increase the carbohydrate load on a patient, that increases CO2 production and that actually delays weaning. However, this is only for if you are overfeeding patients. So there's no sort of evidence. So if you underfeed a patient or do not meet his energy requirements, you're actually now the evidence points that you're actually increasing the risk for morbidity and mortality. So my practice is not to give them the carbohydrates based on their nutritional risk assessment and based on their nutritional needs, rather than keeping a restricted carbohydrate regimen for them.
Okay. Prasad, one more question that should we give 100% of the target feed in first day or in first 48 to 72 hours?
So the verdict is still out on this, Dr. Saib. Studies have shown that if you start off with a low target diet and advance to 100% feed, so it yeah, or in the other population you start with 100% feed, it doesn't actually change the morbidity or mortality of patients. However, the high target group, so these patients have a high incidence of feeding intolerance. They have a high incidence of diarrhea, and they've got a high incidence of malabsorption. And the theory behind it is that in the initial ebb flow, the blood supply to the gut is decreased, and there is some sort of mucosal degeneration of the gut as well. So in terms of what we practice in our institute is we start them on 60 to 70% of their nutritional requirements in the first 48 hours, assess them for feeding intolerance, and then go to 100% of the requirement.
Okay, thank you so much. And one of the person has asked that if he wants to read something for the nutrition, so any guidelines or resources you will recommend for?
So I recommend the European Society of Parenteral and Enteral Nutrition, the ESPEN. So they sound the same. The ASPN is the North American Society, and the ESPN is the European Society guidelines. So the difference between them is what I found is that the American guidelines, they're very much in favor of nutritional risk assessment, while the European societies, while putting emphasis on nutritional assessment, concentrate more on the schematics of nutrition, how to deliver, what type of nutrition to deliver. However, I think they're both very good. The other guideline that you can use is there is the Society of Critical Care Medicine guidelines as well that can be used.
Thank you so much, Dr. Saad. We have with us Dr. Akhtar Waheed, and I think so I can see also Dr. Shabi Jumani as well. Sir, any comments from your side?
That's how. This is Dr. Akhtar Wahid from Karachi. Uh, Now, I'm sure you have an established department of nutrition in your reputed hospital. Now, do you know there are so many intensive care units in Lahore? Have you been in a position to know what is the practice in other hospitals? Because we can learn from each other a lot. And this has been my practice because I worked in two hospitals in Karachi. One is Liaquat National Hospital, which is adjacent to Aga Khan University Hospital. And the last one was in SIUT, where the very well established Department of Nutrition, and we had a nutritionist like you there. The lady used to come every day and assess requirement. I'm sure you must, as regards the parental nutrition, it must be prepared. They must be making it themselves in the hospital rather than importing. Am I correct in my assumption? What I have said
Yes,
just now?
yes, we are preparing our own parental nutrition.
Huh.
So yes,
Regarding
I think the practice regarding nutrition, it differs in different places. So for example, I think you're very lucky that you've got a nutritionist who sees the patient every day. We've got nutritionists who see the patient when the patient is admitted to intensive care, and unfortunately they see the patient in the first 24 hours when they're just being resuscitated, and then and they can't really make an objective assessment of if this patient is going to tolerate feed. However, they are available to us, when we call the nutritionist, they do come and see the patient and make a nutritional plan for patients. So regarding the practice in other hospitals, so there is a wide range of practice in our hospitals. I've worked in a couple of government setups, and what they had was they had for the enteral nutrition, they used a combination of the supplements, of the commercially available supplements like Ensure, and then feeds that were prepared by the patients and their families. So we would give advice to the patients that for example, two bananas or one glass of milk, calculate them from their packaging, what the constituents would be. And for parenteral nutrition, we were using many pharmaceutical preparations that were available in the market. I know that some private hospitals have actually got available the commercial feed. For example, Isocal. A couple of hospitals here in Lahore are using Isocal and other supplements. But I think I'm not really sure. It would be a good research project in terms of finding out what different intensive cares in different cities are using in terms of nutrition supplements.
I'm sorry, I beg to differ with you. I'm entitled to my own opinion because in Karachi, I always kept an eye, and that's why when you have these meetings, they are meant for this purpose. What is your practice and what is your result, and what is my practice, what is my result. Anyway, you can stick to your opinion. I will stick to my opinion. But I'm an old man now. You talked about Ensure. I'm about 83, 84 now and retired. So my daughter, who lives in America, she gave me Ensure today. It was just to boost up my protein requirement and all that. Because I'm a diabetic and hypertensive both. Telling you my own comorbids. Anyway, it was a very good presentation. And lastly, I would say, in your reputed hospital, I was there once when the founder of that hospital was playing cricket in Melbourne or somewhere in Australia. And unfortunately, there was a bomb blast. And I happened to visit that place at that time because I was in Lahore in connection with CPSP examination. Thank you very much. It was a good presentation. And I give my admiration for you to that effect. Thank you.
And thank you very much, Dr. Saab. It means a lot. Thank
Thank you, sir. Dr. Shabir, the last comments, and then I can just close out the presentation.
Assalamu alaikum. Thank you very much, Dr. Saab, for asking me to give the comments. Well, I'm very happy that Dr. Asma and the team have included this important topic in their lecture series. Nutrition is definitely an integral part of patient caring, particularly in ICU, without which I don't think we can have good results, and as recovery, early recovery and early recuperation of the patient, And it was very good lecture, though I joined a bit late, but I was really enjoying it, every bit of it. And I'm very happy that Dr. Saab has present such a nice lecture. Thank you very much.
Thank you, sir.
Thank you, sir. It means a lot that your words, they mean a lot in terms of encouraging us to continue these activities.
Actually, I work in a tertiary care hospital in Pakistan, in Karachi. It's a private hospital, and we do have a nutritionist with us, who rounds, and she's our patient every day, and suggest everything, But unfortunately, we don't have our own production of parental nutrition. But again, our University Hospital, where Dr. Sohaib is working, they are very good in a way that they provide us, with this parental nutrition, and we can use it in our hospital as well. Thank you very much.
Thank you, sir. Thank you, Dr. Saad. So it was like a very good presentation on the updates and guidelines. Recently, what the literature is saying about the parental or enteral nutrition. And one of the thing I just want to emphasize that it's written in the guidelines that it's like ICU is not a place of a dieting. So we need to calculate the patients who are at risk of like a nutritional deficiency in ICU. So we need to see the nutrition risk assessment and then made according to the plan, according to the comorbids, and it's very important because without nutrition we cannot fight with the sepsis, with all the critical illness the patient is suffering from as the patient is admitted. So definitely good nutritional regime and during the ICU stay helps in weaning off the patient from the mechanical ventilation and have a good results, shorter length of ICU stay, shorter mechanical ventilation, shorter hospital stay as well. So thank you
Indeed,
everyone
Dr.
for
Sohaib,
joining.
indeed.
Yes.
I completely
Yeah.
agree with you, 100% agree.
Yeah. Okay. Thank you so much, Dr. Saad, for your valuable time and the presentation. Thank you, everyone.
Thank you very much, Dr.
Thank-
Sohaib, for
Thank you.
inviting me. Thank you.
Okay.